In this VAP, we will discuss the approach to delirium. Delirium is a common condition which doctors encounter in their daily practice. It is important to acquire an approach to aid with diagnosis and management of a delirious patient. At the end of this VAP, you should be able to define delirium, list its causes, describe the important features in the history and physical examination, name the appropriate diagnostic tests, and describe the appropriate management strategies. The hallmark of delirium is alterations in perception and consciousness. There is impairment in maintaining attention to the environment and slowing of mental processes. Delirious patients often are disoriented to time and place, but oriented to person. Changes in level of arousal are common, ranging from agitation with increased alertness to somnolence. As registration of information depends on the ability to focus attention, delirious patients frequently are unable to form new memories and do so only during lucid periods. Hallucinations can occur and are usually visual or auditory. Illusions and delusions are prominent. Other impairments such as language abnormalities, disordered thinking, and emotional disturbances may occur. The sleep-wake cycle is also often disturbed. Delirium is a condition that should be differentiated from dementia. The features of delirium are acute onset and altered consciousness with impaired attention. The cause of altered consciousness tends to fluctuate with lucid intervals. On the other hand, dementia usually has an insidious onset with normal attention and unaltered consciousness. Dementia will be discussed in length in other VAP. There are wide ranges of causes of delirium, both neurological and non-neurological causes. Common causes include central nervous infections or systemic infections, metabolic derangements such as renal and hepatic impairment, hypoxia and hypercarbia, electrolyte and thyroid abnormalities, thiamine and B12 deficiencies, toxins, alcohol intoxication or withdrawal, effects of medications, intracranial hemorrhage, and infarction. History taking from a patient with delirium is often difficult. Try to engage the patients in a friendly and comforting manner in a quiet setting. Information should be sought from families, friends, caregivers, and observers. This is crucial. Prodromal symptoms can develop abruptly over hours to days, with resolution occurring in days to weeks. Hour-to-hour fluctuations of mental status are common. In terms of mental status, one should inquire about the orientation, memory, attention, mood, sleep-wake cycle, presence of hallucinations and delusions. The history should also focus on ascertaining the causes of delirium. One should ask for symptoms related to the central nervous system such as headache, seizures, and focal neurological deficits. Remember to ask about past history of central nervous system conditions such as stroke and brain injury. Pre-existing medical conditions such as renal and liver diseases may help point to the cause of delirium. One should also inquire about fever and other symptoms of systemic illnesses. Do not forget to get details of medications the patient is taking, as well as any exposure to toxins or illicit drugs. Look out for temporal relationship of the initiation of drugs and the onset of confusion. Understanding the pre-morbid functioning of patients may assist in the diagnosis. After obtaining a good history, physical examination will help further with the diagnosis. Examination of a delirious patient is challenging. Vital signs are important as fever, tachycardia, hypotension, and hypoxia can provide clues to the cause of delirium. Level of consciousness should be determined and monitored periodically. The Glasgow Coma Scale is often used to assess consciousness. A neurological examination should be performed. This may be limited by the patient being uncooperative. Signs of meningism such as neck stiffness and Kernicks sign should be examined for. Pupillary light response may provide clues with regards to drug intoxication, raised intracranial pressure, and brainstem pathology. Eye position and extraocular eye movements should be assessed. The limbs should be examined for tone, reflexes, power, sensation, and cerebellar signs. One should also observe for subtle signs of seizures such as nystagmus. Look for abnormal movements such as tremors, myoclonus, and exterixis. Do look for signs of head injury and trauma. Remember to observe for clues of intoxication such as the smell of alcohol and needle tracks. Remember to look for signs of renal and hepatic impairment. A full examination including the cardiac, respiratory, and abdominal systems should be performed. Investigations can be divided into bedside, laboratory, imaging, and other neurological workup. At the bedside, finger prick tests can assess for glucose level and pulse oximetry for oxygen saturation. Important blood investigations include serum electrolytes, renal and liver panel, complete blood count, thyroid function test, toxicology screen, arterial blood gas, vitamin B12 level, and serum folate levels. Brain imaging is often indicated for assessment for intracranial causes of delirium. MRI brain is often more sensitive than brain CT. However, practically it can be difficult for a delirious patient to be cooperative for MR imaging. Lumbar puncture and cerebrospinal fluid examination may be indicated to exclude central nervous system infection such as meningitis and encephalitis. An electroencephalogram or EEG may be ordered to rule out seizures. Intravenous thiamine should be given to all patients with delirium when the etiology is not clear. Thiamine supplementation is inexpensive and virtually risk-free. When the cause or contributing factors for delirium are suspected or identified, one should treat them appropriately. For example, if hypoglycemia is detected, intravenous glucose should be administered. Patients with renal failure may require dialysis. Those with suspected infection should be treated with appropriate antibiotics. Other basic principles in managing a delirious patient include rationalizing medications. If the patient is very agitated or restless, sedation or antipsychotic drugs may be needed. One should try to minimize patient distress as far as possible to prevent the possibility of injury to the patient. It is best to nurse the patient in a moderately lit and quiet room. Physical restraints may sometimes be required, but this should be avoided if possible. Thank you for your attention. We hope this VAP has been a useful summary on the approach to delirium.